I only have 3 friends, so I can't bring that many people, I'm afraid. So
Yeah. I don't know who the call-in user is. It might be.
Michael said.
Starting here in just a few seconds. Gonna wait till it's officially 9 o'clock.
You got your radio voice ready?
I've been practicing all morning.
Me.
Remember we used to have, was it 555-1212 or something?
Yeah.
Time and date.
I don't know. 411. I remember 411. You
Morning.
could just call 411 and
555.
You got your usual spot?
I think I kind of remember that. Yeah, it's been a while. Well, the time being 9 a.m. on February 16, 2022, I'd like to call this meeting to order of Kane County's Public Health Committee. I am Chairman Jared Sanchez. Clerk, could you please call the roll?
Lewis.
Lewis here.
Shepra. Strathman.
Strathman here.
Tepe.
Happy here.
Wallace. Silva. Sanchez.
Here.
Pirog.
Okay, we have a quorum. If someone could please ask for unanimous consent to approve the minutes of January 19th, 2022.
So moved.
Mr. Tepe moves. Is there any objection? Hearing none, the minutes are approved. Are there any questions or comments on this month's finance and budget report for the Public Health Department? Okay, do we have any? We have no one here in person. Is there anyone online that wishes to deliver a public comment on agenda, and we'll also take non-agenda items at this time? Okay, and I see Mr. Shepro has just joined us.
Thank you. Sorry.
No problem, Skin. Okay, let's move on to Executive Director section. Kathy, please take over.
All right. Good morning, everyone. So our first item agenda is on, Michael Isaacson, our Assistant Director for Community Health, is going to be doing a overview of the IRIS electronic referral system that has been very successful at the Health Department. Thank you, Michael.
great, thank you. So good morning, everyone. This is a system that we're very excited about. We've mentioned it in the past. You may remember from last month that this referral system is going to be part of our community health improvement plan in many of our areas. It's very exciting. It's really helping us to connect more of our residents with needed services. So as we're pulling up the presentation here, I just want to introduce the team that's going to be giving the presentation today. And we've really focused this on early childhood and other needs that people have, including mental health and substance use disorders. So the team at the Health Department, I have 3 people here. Sophia Ottamanelli, who coordinates our substance use program, Anna Cerniak, who coordinates our Children's Mental Health Initiative, and Kim Peterson, who coordinates our AOK, All Our Kids Early Childhood Network. They've been doing an amazing job implementing this system. It just launched in March. And one thing that I ask you to keep in mind as you're listening to the presentation is, are there organizations that you work with that perhaps would be valuable to engage in this system? So you'll see that we have a lot of people already involved in this, but there's a lot more growth opportunity for us here. So any ideas you have, we'd definitely like to work with you and get more people signed up. So with that, I will turn it over to the team and share a little bit about the system.
Great. Good morning, everyone. So I am Anna Cerniak. So I'm going to just start off talking a little bit about IRIS. Can I see the next slide, please? All right. So what is IRIS? So IRIS is a web-based communication tool to help organizations connect the families they serve to the right resources in the community. So essentially, IRIS stands for Integrated Referral and Intake System, and it's a web-based referral tool that providers can use to make referrals on behalf of their clients. So for example, if a behavioral health care provider is working with a family and they identify that the family is in need of maybe rental assistance, or they qualify for a home visiting program, the behavioral healthcare provider can very quickly and easily make a referral to those organizations on behalf of their client. And then the organization accepting the referral then reaches out to that particular family to get them connected with services. So like I said, Iris is technology enabled. So this is something that you can use on your computer. You can use it on your phone. With the Iris system, it has closed referral loops. So this is one of my favorite features of Iris is the communication that you have throughout the status of your referral. So when you make a referral, you're notified when it's been accepted. If it's rejected for any reason, you're also notified of that. And then you're notified with some sort of disposition when it's been completed. So either the family has been enrolled in services or there's some other disposition. But then once you know that the family's referral has been accepted, that closes the referral loop. With Iris, we also have standardized referral forms. So we want this to be a system that is really quick and easy to use. So we have a very simple kind of general referral form that every organization uses when they're making a referral on behalf of their client. This allows for real-time notification. So like I said, you're notified via email when anything, so if you make a referral, if you receive a referral, if there's any activity on your referrals, you're notified right away via email. And it also has a partner capacity indicator. So again, this is another really cool feature of Iris. So it shows you the estimated wait time for a particular program or service. So again, if you're looking to make a referral to someone for behavioral health care services, if there's several organizations that may meet your client's need, you can look at the capacity bar to see what organization can get the client in the fastest. It's also data driven. So this is a HIPAA compliant system. So we get a lot of questions about that, but this is HIPAA compliant. And it allows for meaningful reporting. So we're able to run community-wide reports on all of the referrals that are going through the system. Each individual organization who is a partner on Iris, they can also run reports related to the referrals that they are sending and receiving. There's detailed search capacity. So again, it's really easy to go into the system. If you're looking for a particular resource, we have different search filters. You can search for a service that you're looking for. You can search for a location. So it really narrows down the resources that are available. So again, you're connecting the client with the right resources for them. And it provides support for collaborative decisions. So again, there's so much data that we can pull from this. It definitely allows for some data-driven decision-making, but we also host a quarterly data meeting with all of our community partners. And this is where we talk about what we're seeing with the data. And again, we can kind of make collaborative decisions as a group. Next slide, please. All right, so backing up a little bit. So prior to Iris, what we were seeing with referrals were King County residents were not getting linked with available and needed resources in a timely manner. So there was all sorts of things that were kind of happening along the way in the referral process. So there may be delayed responses to referrals. So again, you may call an organization to make a referral. You may not hear back for a week or two. There was no transparency with wait lists. So if you're in need of a service and there's multiple providers, you'd have to call each provider if they have a wait list to determine what is the shortest wait list. And families would fall through the cracks during the referral process. So just an example, this is a very common example. If a family changes their phone number during the referral process, the organization that's trying to contact them would be unable to contact them. With Iris, there's this communication feature. So if someone makes a referral, and the phone number, changes throughout the process, they can reach out to the person who made the referral, the professional, and say, hey, do you have a new phone number so I can contact this family? So it really helps to make sure that clients are getting connected with the resources that they need and kind of overcoming some of these barriers. So another thing that was happening was King County providers lacked an understanding of available services and missed opportunities to make referrals. So our county is so large and there's so many awesome resources in our community, but it's nearly impossible to know every single resource that's available. So again, with Iris, this makes it really easy for people to search for the resources that they are looking for, and then any organization that provides that pops up. And then the paper-based referral process was tedious, inefficient, time-consuming, and not always HIPAA compliant. So prior to Iris, people were making referrals through email, which is not HIPAA compliant. They were making referrals by fax. Sometimes they were just like calling, and again, like pen and paper, things like that. So it just was not a super efficient system. So then the solution. So this is kind of where Iris comes in. So we determined that there was a need for a different way of working referrals in our community. So we found Iris. And some of the different, and some of the additional things that Iris does. So it can increase operational efficiency and enhances existing referral processes for organizations. It offers streamlined communication for care coordination. So as I mentioned earlier, the ability to be able to communicate back and forth with the person who has sent the referral and the person who has received the referral is really helpful. It's a collaborative platform that strengthens relationships amongst providers. It brings transparencies to organizational capacity, leading to shorter wait times. So, I mentioned the capacity bar. So this is really, really critical, especially right now, because so many organizations, especially for mental health, have really long wait lists. So if you're able to kind of take a look and, referrals are being distributed more equally, this is definitely going to shorten wait times. It also allows visibility into real-time data to understand referral patterns, average referral response times, resources that are being over or underutilized, and service gaps. So one thing we do track is the average response time. So what that means is when you make a referral, how quickly are other organizations responding to that? And when we developed our community standards with all of our community partners prior to launching Iris, we had determined that each organization would have up to 5 business days. So it's pretty much guaranteed if you're an Iris partner and you accept referrals that you'll respond within 5 business days. However, it has been much shorter. So some referrals that I've made are responded to within minutes. But I think about the average response time right now is about a day and a half or 2 days. So now I'm going to turn it over to Sophia Adamanelli.
Hi, I'm Sophia. I am the substance use coordinator. And I'm just going to talk a little bit about Iris stats. So we really laid the groundwork for Iris in 2019 and were able to launch the system on March 15th, 2021 with an initial cohort of 60 community partners. That since has grown to 104 community partners, which is just absolutely awesome. And it represents multiple sectors of services, including behavioral health, substance use, primary care, dental. We even have a free clinic on board. So really a variety of programs that can help community members. Next slide, please. And this is just an overview of some, or actually all of the partners that we have currently on Iris. So you can kind of see the variety that is included and just how many people are actually on it, which is just great. Next slide, please. And we want to just share a little bit about our impact in 2021. So in 2021, we had 624 families that were able to be helped in the system. We had 1,124 referrals made in 2021, which actually, as of today, has grown to 1,352. So that's great because more and more referrals are being made. And we have 104 partners that are part of the system. Next slide, please. And this just goes to show a little bit of that response time that Anna was talking about when people are accepting or rejecting the referrals. So in October, it was an average of 1.8 days to get a response. In November, it was 2 days. And in December, it was less than a day, which really goes to show that our partners are responding quickly to the referrals, even though they have that allowability of 5 business days to respond. They are responding quite a lot quicker. And on this left side, you can just kind of see the breakdown of how many organizations are in each sector. So like, for example, there are 16 behavioral health organizations that identify that they have some sort of behavioral health service. There's 30 organizations that identify that they have some type of family support service. So it's kind of great just to see the breakdown of what each organization has, because then people can cipher through and see what organization is the best fit for their particular client. Next slide, please. And this is just some of the referral trends since launch. So it does only go up till December 15th, but you can kind of see how the referrals have gone. They have increased almost every month, and it's going to continue to increase considering we have 1352 referrals as of today. So this is just great to see that the system is being used and it's being utilized to its fullest extent. Next slide, please. And so now I'm going to hand it over to Kim Peterson.
Hi, everybody. I'm Kim Peterson. I'm the AOK Early Childhood Network Coordinator at the Health Department. And in addition to what my counterparts have just highlighted about the IRIS system, we also use data visualization tools like, as you can see, this Kumo IO program. And as Anna was mentioning, IRIS gives us and our partner organizations a unique ability to right away just run these reports through the IRIS system and target different data points that we want to really zone in on and look at. So this was what our referral pathway map looked like back from our launch in March, on March 15th to May 15th. So that was our first quarter. So as you can see, our iGrow home visitation coordinated intake was our biggest participant in the system at that time, and new pathways were being established all the time with our initial group of 60 pilot partners. Next slide, please. Then you see this mess. This is from March 15th to September 15th. So in our second quarter, as you can see, the pathways are growing, our partners are growing, and the size of the circles there indicate, how much participation each organization is engaging in. And then the arrows indicate the referral pathways from partner to partner. And with this tool, when we're on the interactive site, we can, click one of these circles, organizations, and really just zone in on only what they've been doing. So this also helps us kind of look at the whole community and kind of understand who's referring to who, and then in outreach workers at each organization that have to report to their grant funders about community partnerships are reporting that they're very happy with this tool because now they can prove who they're interacting with, who they're partnering with by running those data reports. And same with us when we're working with our grant funders. So it's really a win-win. Next slide, please. And then this, it's a little light to see because there's just so much. This is our third quarter data. And as you can see, there's just so many partnerships and so many referrals being sent. As Sophia said, above well, at that time it was like 1,200 something. But what we're seeing is, folks like, I always say, Jerry from WorkNet in Batavia, he's forming new partnerships. He never thought of referring any of his clients to anyone else because, he's there to help them use the computer and make their resume and find a job. But as we gave him this tool and he really understood how to use it, he started talking to the people that come in a little bit. You're looking for a new job. Do you also need childcare? Do you also need maybe clothes for your interview? Is there anything else you need that can support your job search, your efforts in this way? And he's been able to kind of branch out and really refer his clients to those other supportive services so they can meet their goals. And this is kind of the great work we're seeing naturally through this system. And as you can see, it's growing. And we just want to say also that we have major champions in our community, like, of course, Michael, making sure that we can find the funding and keep this project going and giving us the autonomy to kind of move forward. And we always consult our partners. We listen to all of our community partners when we're making changes to the system, when we're developing the system. So they really feel involved and dedicated to this project as well. And as we learn from this, we're not even at our year mark yet. But they always are giving us feedback, and it's kind of like a continuous QI cycle. And we're really learning from this. And also, Laura Barrett and Katie Glomp from the coordinated intake system, as you can see with their huge dot there, they make a ton of referrals. and they're huge champions of this. And Laura's always going out talking to the hospitals and different folks about this tool. And our long-term dream is to, have this in primary care offices. So when the doctor's too busy to kind of go through referrals with the families and things like that, that they can just go to the front desk. Front desk can have this tool and refer them out to those services that they need that will improve their health in the long term. And also our court services folks are Martha Paskey and Latanya Hill. All our probation officers are on here, and they use this tool very heavily. And they're all encouraging their community partners to join. So this has just been such a great collaborative and successful effort. And so that's why we ask if you guys know of any organizations that would really benefit from utilizing this tool to send or receive or both referrals to expand their visibility within the community. Talk to them or connect them with us, and we can meet with them and just give them the information. It's free to all organizations as the health department is paying for it. And it really is establishing the health department even more outside of COVID as a place where our community partners come for information, come for resources, and turn to kind of establish system improvement efforts throughout the county. So it's been really great experience, and I hope you guys can support and promote it when you see fit. Thank you. Any questions?
Louis, can I ask a question?
Go ahead, Ms. Lewis.
Okay, first of all, if we see a organization that we would like to have you get in touch with, who do we send that email to?
I'll put all of our emails, or we'll put all of our emails in the chat. You can send it to one of us, myself, Anna, or Sophia, or all of us, and do like we like those virtual introductions. But even if you just send us like, hey, I talked to this person, here's their email, we can do the outreach.
Okay, perfect.
Thank
And
you
then
so much.
secondly, so I really love the fact that you're getting these referrals done in such a timely manner. Do we have any data on once those referrals go out, like mental health? We get the referral out there. What's the wait time of people to actually get those services? Because I know I have heard that it's months sometimes to get a mental health appointment.
Okay, yeah, Anna, go ahead.
Yeah, so it really
I know it's not really in the league, but I was curious, and I know you guys know.
Yeah, so it really varies depending on the organization. So when you go into Iris, you can see on the capacity bar, it gives you an estimated wait time. So it'll say, 1 week wait for outpatient therapy, or 4-week wait for psychiatric services. But we don't track. So we track it in the sense that when the referral is completed, that means that the family has been taken off the wait list and connected with services. So we track the average length of time for referrals to be completed, but we don't necessarily track per se. So we can't look at each organization and say, okay, this organization has, we've been able to track through data, and we see that it takes approximately 2 weeks for a client to get connected with services. So we're not able to track that unless Kim or Sophia.
No, go ahead. I get it. I was just kind of curious, but the fact that they give you that data that says that, it's going to be 4 weeks or something, that's a pretty good start, because I'm assuming that, when we send referrals, we say it's probably going to be a 4-week wait or whatever. So, yeah.
So
perfect.
Anita, that I just want to add that is a really big issue right now, and the transparency within the Iris system with the capacity bar that folks are mentioning, they usually, our mental health organizations will put right on there. If they're in the red, they'll say there's a 2-week waiting list, or I think I looked at Family Service Association and they said, 2 months for English speaking, 6 months for bilingual. So this does give us that qualitative data information about the likelihood of being engaged. And again, as we all you decision makers move toward data-driven decision making, this can help them write for funding for additional staff to meet those needs, because they can prove, here's all these referrals sitting in the system. We can run these data reports. We need another staff member, so we need more funding. those kinds of
Mhm.
things. So it's not exactly what you're saying, but there are ways we can look at that.
Yeah, no,
Thank you.
no, perfect, because I know it's a big issue and I was just curious.
Mhm.
One last thing, and then I'll turn the floor over to somebody else. I love systems. Is there a way that I can see an online demonstration? Can I come to your office or?
Absolutely. Our online, we love doing that.
Yeah,
Our
okay.
online demonstrations, it's easier on Zoom, Anita, just because we can kind of show you, we can go into the system and show you everything more easily. So, but if you'd rather come to the office, we can do that too. So just
No.
email one of us offline and we'll be happy to do that.
Okay, maybe, hey Jared, maybe we could set up a Zoom thing and any board members that want to view it, we could do that.
Sure.
Okay, you want to take the lead on that or do you want me to?
I'll let you take the lead.
Okie dokie, thank you.
Thanks, Anita.
Thanks, no, thank you, this is exciting.
And
I missed
I uploaded just like a one-page kind of document that just has a little bit of the information that we discussed today, but it also has all of our email addresses on the bottom of it. So if you want to share that, feel free to share that flyer with any organizations in the community that you think would be interested in IRIS. And then it also has our contact information. So like Kim said, we love to do demos. So just let us know and we'll be happy to schedule something.
Mr. Tepe?
Thank you, Mr. Chair. Tepe here. I'd like to really commend how effective this has been. Historically, if you go back, Mr. Isaacson and his staff, they coordinate a meeting. I believe it's every 2 months now. For a while, it was every month, but every 2 months with the primary mental health and support organizations in the county. And one of the key needs that he recognized quite some time ago was that somebody coming into an organization quite frequently had other needs that couldn't be met by that organization. And that organization either had no way or no knowledge as to where or how to refer that. And I think the beauty of this is something that Mr. Isaacson and that group has done is that key members of that organization that are independents were part of helping make IRIS work, because all of the organizations that are participating this are participating on a voluntary basis. And they're using it because they're able to use it effectively to help people get other services. And I used to gently refer to Mr. Isaacson's group is that, you know, he was managing a group of cats. Okay. But, you know, these are people that are independent, but also are really trying to fulfill a need in this community. And this tool has been embraced by virtually all of these organizations because it enables them to do a better job of helping people. And the support that the staff gives with this is just greatly appreciated. So I've been attending, you know, Michael's meetings now for well over a year. We have one either this afternoon or tomorrow afternoon. I know it's on my calendar, okay? But I really want to commend the fact that this works, and this is just a key example of what the county should be doing. And it's something that we should all applaud. Thank you.
Thank you, Mr. Tepe. Anyone else with a question or comment?
Mr. Chairman, this is Alan.
Ms. Allen, go ahead.
Thank you. I'm not on the committee, but I do remember the beginnings of this group, and it's just marvelous to see it work out as a tool that people can use. No one wants to get bogged down in the next report I have to fill out, in the next form I have to fill out, and if this is something that our caregivers, our social agencies can use quickly and easily, and it hooks us all together. I mean, that's just like a miracle. I wanted to ask this question. Let's say that someone comes to ask for help for their family, saying that marital problems or something like that. And it turns out that the parents are having trouble dealing with a child who maybe is autistic, something that's difficult to diagnose. Is that something that has an answer? Is that something that can be referred out because somebody says, oh yeah, we've got a tool, a resource for that? Can I ask that question?
Absolutely. That's a great question. We do have our Autism Providers on board. So we have a couple different organizations that are ABA based. They do medical diagnostic evaluations. We also have our state early intervention program where if a child is exhibiting symptoms on the autism spectrum before age 3, they can be referred through IRIS. So again, let's say the family is engaged somehow within somewhere in the system, that provider can go in and say, okay, you need services for your child with autism to support their growth and development. And then you also need services, if you're having also marital problems, we can refer you to a marital therapist. And we can do that all at one time within this one system and eliminate all the barriers for you, because those organizations are then going to call you to engage after you've expressed that need, instead of just giving the family phone numbers and having them go through this nightmare on their own. Of like calling different places, being rejected, insurance, because within the system, you also indicate what type of insurance and or Medicaid and or no coverage that the family might have. So yeah, the answer is yes, the short answer. And we're currently trying to branch that out and deal with the kind of insurance issues that go along with ABA in our state.
This is spectacular. Please have the energy to keep up the good work. Thank you.
Thank you.
Any other
Mr. Chairman,
questions or comments?
Strathman here.
Go ahead, Strathman.
I just want to tell this group that this is an amazing program, and I can tell all the work that has been put into it. Thank you so much for carrying and doing this. And I also would be very interested in attending the Zoom to learn even more about it. Thank you so much.
Thank you. We would love to have you. And we will invite you guys to our quarterly meetings. Michael can let you know our annual meeting actually will be coming up next month, or maybe end of March, early April. So he can let you guys know when that is if you want to pop in. That usually includes most of our organizations, a representative from most of our participating organizations, where we go over high level data and kind of do some QI with the whole group.
Mr. Chairman, Alan, question again.
Ms. Allen, then Ms. Gums.
How would we recognize that? Is that referred to as the IRIS working group, or how would we recognize that when Michael lets us?
We call it the IRIS quarterly meeting. I mean, this one will be the annual meeting because it'll be the 1 year. So it'll just be the IRIS annual meeting.
That's great. Thanks.
And you can also follow the I do a lot of work on the AOK Facebook page, and I put all of our updates and media coverage and press releases on there often. So if you follow that page, you'll see the information about that there too. And I'll put that link in the chat.
Ms. Gums?
Great.
Just a really quick question. Do you guys engage, would you do like a town hall? Would that be something you guys would be up for?
I think we're up for anything.
Yeah,
Absolutely.
because
we love to talk about IRIS. So
yeah, because a lot of folks don't know about this. I mean, just regular people, they need to know where they can go, and I think that would be a great thing to do. So thank you.
Yeah.
I'll be in touch.
Thank you.
Good
Mr.
idea.
Isaacson.
And I obviously the team has done such an amazing job with this. So I can't praise them enough for the work they've done. Just a couple of additional comments. We've paid for this with private grant dollars, so no tax dollars have gone into this. There's absolutely no cost for our community organizations to participate in the program. So we have a sustainability plan for this going into the future. It's very cost effective. It's less than $10,000 a year anyway, but we've been able to secure private funding for that as we move forward. So please, if you know of any organizations, send them our way. And this was a static demo today, but as the team mentioned, being able to get in and actually see how it works is even more impressive. So we definitely look forward to doing more demos for all of you.
Yeah, it'd be great to do the Zoom demo, maybe invite committee members and then record it so we can have that out there for
Excellent.
others to see.
Yes.
Mr. Chairman? Bates, please.
Ms. Bates.
Do you have funding for many years, or how long is your grant for?
So we do have funding secured at least for the next 4 years. But
Good.
the actual cost of this is about $7,000 a year. So it's something that I have full confidence we're going to be able to continue to find funding for to keep. And I think even at this point, nobody in the community would let us get rid of it at this point because people are already so bought into it.
Good for you. Thanks.
True.
Mr. Chairman, Alan again.
Ms. Allen?
One of the other things that's helpful here, the ripple effect in the pond, we are always trying to figure out, let's say this, we have ARPA money to give out, but we are concerned that if we use ARPA money to fund a staff position, when the ARPA money, I mean, obviously the staff positions are needed all over the network, but we are concerned that when the ARPA money is gone, then how do we continue to support that staff? And this data, I think, will be immensely helpful for organizations to prove the services they are providing, the staff they have and the staff they need. It just helps to have that solid information behind you when you come asking somebody for money. So I think that's an unintended consequence that will have a long-ranging benefit for policymakers who are trying to decide how to spend money. Thank you.
Kathy, Michael, do you guys know if we've posted about this on our Facebook or any social media, looking for more providers to add to the network? We have?
We
Okay.
have, yes,
Okay.
absolutely.
Yeah, good. As long as we got that base covered, just to help get the word out some more. All right. Any other questions or comments before we move on? Okay. Thank you to everyone who presented today. It's an amazing system. I've been hearing about it since we got going on it, and it's glad to see that we have 104 providers, our community partners so far, and the list is growing. So thank you all for being here. Okay, I think
Thank
we have
you
our-
so much for giving us this opportunity.
Absolutely.
Thank you.
And Anita, follow up with the Zoom walkthrough for everyone, and make sure you talk to the state's attorney too, because we always
Yeah,
have
will
open
do.
meetings.
I will probably set it up as an open meeting and I'll just maybe,
All right. Yeah, we'll
get
talk
with you and
offline.
we'll
I
get
appreciate
with
it.
you and we'll set up as a special meeting. That's the
All
easiest way. Okay, thanks.
Okay, we have our COVID-19 update.
Yes, and I just want to say to the team, thank you very much. Great presentation today. So with COVID updates, we have our Director for Health Protection, Uche Anwuta, who's going to give us a brief update on COVID.
Good morning. Let's get the next slide. Okay, so even I myself had almost forgotten what the different categories of transmission are because we've been in high transmission forever. So I wanted to start with that. So for us to go from, currently we're in high transmission with over 100, case rate of over 100 per 100,000 in the past 7 days. And our positivity rate has come down some. So we have to still be in high transmission until both indicators have gone down. And then with substantial transmission with a case rate of between 50 and 100 and 8 to under 10% positivity rate. So both substantial transmission and high transmission are considered, we're asked to wear masks indoors and in public settings. And then once we come down to the low transmission and moderate transmission, then only unvaccinated people should wear masks in public indoor settings. So you can see why there's concern with the public health community, what to do as cases are coming down and people are getting restless about, COVID guidance that the public health is giving. So having said that, we're still in high transmission. Right now, we're 231 per 100,000. Just for reference, in November, we were at 139 per 100,000. And last month, when I came to make the presentation, we were at 914 So we're making very good progress. It's just that we're not there yet. Positivity rate has come down to 5.85%. So far, our total number of cases, 123,000, over 1,000 deaths. And our hospital admission in the last 7 days has come down to 65. So as I mentioned, looking at the graph on top, Omicron, came hard and fast. We went all the way up, and now we're coming down, quite considerably in terms of cases and our deaths. So this is a page out of the daily report that we get from KPMG. Looking at the graph again, it shows that we're consistently coming down in the number of cases. Yesterday, for some strange reason, we went from the top left corner. Our weekly average is 175. And for some reason, yesterday we were at 332 cases. So it tells you how fluid things are, things keep going up and down until they finally stabilize. So it's not like a one-day effort. So I usually give you information about the variants in Kane County. So we still have a little bit of Delta. We had 8 cases and 136 of Omicron. So even though Omicron is the dominant strain, Delta is still rearing its ugly head, but not by that much. And so far, we haven't seen the BA2 variant in Kane County. Having said that, with our genomic sequencing, it takes time, specimen collected now will probably take, sometimes it could be a month before we get the results in. So our CD staff did a good job to put some slides together that I included in my monthly report. So this is looking at Omicron cases by age. You can see that, a lot of younger people were positive for Omicron, and not surprisingly, the older population are more fully vaccinated. So, but the younger population had some issues with Omicron. So looking at our outbreaks, as of February 10th, we had 56 outbreaks, 9 in school and daycare centers, and 47 in congregate settings. So total so far, we've had 495 outbreaks since the beginning of COVID-19. And in 2022 alone, we already have 25. So the city folks put together some slides for deaths as well, which is interesting. This is just looking at deaths that were caused by COVID. You can see earlier, end of 2020, we had the highest deaths. This was right before vaccination, and then, the downward slope. And, we slowly started to climb up with Omicron coming in here. This is up to Q1. This is January of 2022, the number of deaths we had so far. Oh, I didn't, let's go back. So more males than female deaths. So looking at the age breakdown of the deaths, we have, most of the deaths in the 70s. And then now looking at the deaths we've had since December 1st, kind of looking at where we are right now. This is the whole COVID, the pandemic starting from March until now. So looking at the whole pandemic, knowing that in the early days, we had more deaths with the older population. And then the next slide looks at deaths from December 1st until present. And you can see that we have younger deaths right here, 50s, 60s, all the way to 95. And we actually had a teenage death, 16 to 20-year-old. Okay. So far, our total population with one dose of vaccination, 73%. We're still at 65% fully vaccinated. The population with booster doses, only 48%. Population 5+, about 78%, 5+ with one dose vaccination, and about 70% fully vaccinated. And as I mentioned, the 65+, 86% of them are fully vaccinated. So I always have this just to let you know that anybody who is 5 years and older is eligible for vaccination. And hopefully by the time we come back next month, the 6 months to under 5 will join this group as eligible for vaccination. So that's all the information I have today. Any questions?
Mr. Tepe?
Thank you, Mr. Chair. Tepe here. First off, I'd like to say that I've been looking at the numbers of vaccinations that have been given at the Vac Center. And a few weeks ago, I sent an email to Ms. Fosser, and I suggested that I think it's time for us to consider closing the Vac Center. We're getting down to the point where it's 100 people or less a day that have been getting vaccinations there. And I think the health department has done a phenomenal job of saying, here are the other locations and other events that are happening. And if we could continue to communicate and get that kind of information out, I think it would be time for us to seriously consider closing the Vac Center. I'd also like to recognize all of the people with not only our own health department, but also the additional people, and in particular, the volunteers who really helped to keep that Vac Center open. And I'd like to hope that there would be some event or some level of recognition that we could do for those volunteers in keeping that happening, okay? And my last comment is that I urge people to wear a mask whenever they feel uncomfortable, okay? I just heard the suggestion that unvaccinated people should wear a mask. They don't, okay? And it's the fact that they don't that, in my opinion, other people continue to get infected. So I strongly advise people that are in any way concerned, wear a mask. Because the people that are causing the issues today and that have been filling up the hospitals just won't get vaccinated, and they just won't wear a mask, okay? But, I really want to thank you and commend the health department for all its work in this particular area, okay? And thank you.
Thank you for your comments, Mr. Tepe. And I'd like to echo your comment that we should seriously be looking at shutting down the mass vac site. It's definitely served its purpose, and I think it's time to move on to our next model for vaccination. Mr. Brown.
Yeah, thank you, Mr. Chair. I'm not on the committee, but I do have a couple of questions for you. When it comes to the numbers, which is what we all look at, how reliable are the positivity numbers now with everybody doing at-home tests? How reliable are these numbers?
Thank you for that question. And I realized that I didn't put that information in the slides. Right now, positivity rate is not a good measure of the incidence of COVID-19 in the community because we have so many home test kits. So people test at home, and if they're positive, they hopefully do what they're supposed to do, which is isolate and inform their close contacts. So the positivity rate only captures viral tests that are officially done in the labs. So it's not a good measure. And actually CDC is considering not using positivity rate as a measure and focusing more on hospitalization, ICU bed availability. Those kinds of things are what they're focusing on right now.
Yeah, that makes sense to me because it works both ways. If people aren't reporting negatives, they're not reporting positives. So it just throws the numbers completely askew.
Right.
The other question I have, Jared, if you don't mind, is on your chart when you showed deaths by months. For January of 2022, you had 104 deaths. But the coroner's report in the Judicial and Public Safety Committee meeting that he hands out every month for January, he had 158 deaths from COVID. So is that just a timing of when they're reported, or is there, why would they be different?
So the coroner's report is different from the deaths that we track. We track people who died of COVID regardless of where they are, who are Kane County residents. The coroner tracks only deaths that happened in Kane County. So if death happened in any of our hospitals or at home in Kane County, it will be tracked as a Kane County coroner's Kane County death. Now, if you died at Cook County Hospital and you're a Kane County resident, the coroner will not have that information. So our data are very different.
So it would seem to me as though that your numbers would be higher than his.
Not necessarily, because since we have 5 hospitals here, for instance, Rush Copley is used by Kendall County and all the other counties around it. So if somebody dies in Kendall County, if a Kendall County resident dies at Rush Copley, it will not be a death. However, these are deaths that occurred due to COVID. People die who test positive for COVID, and they're not included in this report.
So the coroner tracks all COVID deaths that happen in Kane County. Our data is just showing Kane County residents that have died from COVID, even if they were in Florida,
Wherever
Tahiti,
they live.
Illinois.
Right.
Yeah.
Mm-hmm.
Okay.
And this is a subset of all our deaths, just focusing on COVID being the cause of death.
Right. Okay, thank you.
Mm-hmm.
Any other, Bates, go ahead.
Now this seems like maybe an irrelevant question, but what did you say the test positivity rate is today in Kane, please?
5 point something.
5.5.
Yeah.
So even if people are testing at home and not reporting, at least the people who are testing in the clinics are giving us a subset, correct?
Mm-hmm.
So I'm wondering statistically if that is still accurate in a certain way.
It's not. The test positivity rate is those who tested in the lab, the results that we're getting from the labs. So the home test kits, whether they test positive or negative, are not included. And for the test positivity rate, we need to have both the positive and the negative to be able to calculate it. So if they don't report the negatives and only report the positives, the positivity rate will tend to be up. So just because of the home test kits, positivity rate is not a good measure for COVID.
It seems like that's been our most important measure up till today.
It was until we started pushing out home test kits in the last month. So prior to now, test positivity rate was a good measure. But now that the feds pushed out millions of test kits and encouraging people to do these tests at home, I myself got 2 packs of those that I can use at home. I'm not going to report it to the health department, not because I don't want to, but because they're saying don't report it.
They're saying don't report it?
Right.
So that number is now meaningless. Our test number is positively is now meaningless. So how do you know when it's safe to go out?
Again, the benefit of the home test kits is that you do the test at home and you properly isolate and inform your residents, making individuals responsible for their infection. So there are, positives and negatives of each decision.
And I think what Mr. Tepe said is really relevant to answer that question. How do you know when it's safe to go out? Well, if you're concerned, the N95 and KN95 masks are the way to go. Obviously, cloth masks won't protect you. They just reduce your output, but that's certainly, as we're going through this still, the N95 masks are the best way to go. Properly fitted.
Thank you.
Any other questions or comments? Okay, let us move on. We do have a resolution. If I could get a motion and a second for authorizing acceptance of fiscal year 22 COVID-19 response grant agreement. Anybody like to move and second?
Tepe moves.
Tepe moves.
Strathman second.
Strathman seconds. This is another one of those feel good. The state wants to give us money resolutions. Kathy, can you just briefly describe this for us?
Yes, I will actually let Uche explain this grant.
Yes, so this is a grant that the IDPH is giving us and is going to help us to do testing, COVID testing at the Batavia facility, Carpentersville, and hopefully a site in Elgin. It's fully, all we're doing is just a resolution for it, in addition to addressing some of, paying for, some of our salaries for our employees are included in this as well. So less money from the local funds.
So this mentions surveillance. Does that refer to contact tracing?
So the surveillance is the employees in my program, the CD program.
Okay.
Our regular employees, yeah. Some of their salaries are going there.
Total of $775,000, so not too bad. Any questions or comments on this, Mr. Brown?
Is that for future expense or past expense or both?
Future expense. This is for December, January 1st to December.
Okay. Any other questions or comments? All right. Let's have a roll call for vote.
Lewis?
Absolutely.
Shepro?
Shep.
Strathman?
Strathman, yes.
Tepe?
Tepe, yes.
Sanchez?
Sanchez, yes. Okay, resolution passes. Now we move on to animal control. Brett, are you on the line?
Yes, everyone. How are you today?
Good. How's it going?
Very good. Sorry, I'm just pulling up my report here. So we're revenue exceeds expenses, which is what we always want to see every month. And if anybody has questions on that, of course, please let me know at any time. We did post our first 3 vaccine clinics of the year. Our first one will be April 23rd. It's a Saturday from 10 a.m. to 1 p.m. We have our May 11th date, which will be a Wednesday, and our June 4th date, which will be a Saturday. We're coordinating with 2 veterinarians, so it takes a little bit of time to get the rest of those dates out, as they're going to be in August, September, and October. So we hope to have those within the next month or 2, but we're very excited to get our first 3 dates posted. We've already sent them out to the senior communities and a couple of other of our partners to start posting them through miscellaneous places throughout the county. We'll be putting together a press release shortly as we get a little bit closer. We just we like to get the dates out as soon as we can. We've already had tons of calls about them, so we're very excited to get that going for the year. And of course, if anybody has questions about that, I'm always available. The other thing I brought forth today is a discussion item that I emailed to everybody. Throughout COVID, we've had a lot of calls about if people had to come to the shelter to purchase tags, and is there other ways to purchase tags online? I know some other counties have done some things through their counties. So we did some research with our system to find out how much it would actually cost the county itself to do this sort of procedure, and it would cost about $10. The reason I wanted to bring it forth to you is that's only if we sell 500 tags online. Considering we only sell about $13.30 a year, it isn't financially feasible, especially a $10 charge for a $12 tag. I have a lot of difficulty with that. This isn't something we'd be able to sustain ourselves, but I wanted to bring it forth to the committee for a discussion to see what everybody else thought, because we do spend about $32,000 a year with a 2% increase every year going to IT, that I didn't know if the county felt 2,000 of that funds better utilized going to something like this. So I felt it best to put it forth before you today to kind of get everybody's opinion. And thank you to the few board members that have already reached out with questions. I do greatly appreciate people looking at this, taking it seriously, and giving me feedback, because I really do appreciate that.
And Brett, we appreciate you bringing it to us. Obviously, within your budget, you're able to make decisions on your own like this, but you wanted to run it past us and get our thoughts. And that being the case, is there anyone that has any conversation they'd like to engage on this?
Lewis, please.
Lewis, go ahead.
Yeah, so I was one of those that reached out to Brett and asked him, because, I get my stuff from my vet, it's kind of like automatic. And he did say that about 95% of the people get their tags either from their vets or clinic. So for me, why I get the fact that it's a convenience to do that, because there is so low numbers, it seems like it's just another thing that our animal control people would have to be handling, and also an expenditure. It's not a huge expenditure, but we do so many good things that I think we could just use that money somewhere else. So I'm not for this.
Thank you.
Ms. Lewis, you're not for the idea at all, or just the idea of using, are you for the idea of using the IT money, or?
I'm just not, I'm not for doing it online. It's just such a small group that we're going to service.
Gotcha. Mr. Tepe.
Tepe here. I spoke with Brett about this also, and I concur with Ms. Lewis. It doesn't look like the expense is worth the convenience or the cost that we would have associated with this. Again, the majority of tags are sold through the vets and the veterinarians, and they do a great job of coordinating with the county. So stay the way you are, Brett.
I completely agree. I just wanted to make sure that everybody knew that we did look into it, and we are trying to do everything we can to help the community in any way.
All right. And if I receive any other comments from committee members, Brett, I'll send them your way.
Greatly appreciated. Thank you, everyone.
All right. Any other questions for animal control before we move on? All right. We have nothing for old business. Can I have a consensus to place the reports on file? Someone ask for unanimous consent?
Unanimous consent to put reports on file.
All right. Tepe asked for unanimous consent. Any objections? Reports are now placed on file. We have no need for executive session, nothing for new business. Public comments on non-agenda items we've already covered.
In honor of Mr. Kenyon, I'd like to move for adjournment.
Strathman seconds.
Kenyon honorary adjournment motion. Strathman seconds. All those in favor say aye.
Aye.
We are adjourned. Thank you for being here.
When I first went on the Farm Bureau Board, we'd bat at night, only still go. And you get done with the meeting and they.
I didn't ask Madam Chair's question, but yeah.